All right, to kick off our afternoon session, we have Stacie Zellin, a community strategist from Prevent Ed, and she will help us explore connections between substance use and mental health.
Okay. All right. Good afternoon, everybody. Hey, the post-lunch lull. Excellent. Can everyone still hear me okay from here? Feeling good about that? Okay. If I need to step over to use the mic, please just kind of give me a little signal. I'm happy to do that. So my name is Stacie. I work for Prevent Ed. We are a nonprofit, also a prevention resource center located up in the St. Louis area. So we serve that eastern region of Missouri. Let me just tell you a little bit about what we do. I think it's nice to put a face with a name. We work to prevent and reduce the harms associated with substance use. So the bulk of our agency's programming is actually in schools. We do school-based prevention education, so that starts as early as kindergarten, and then we go all the way up through 12th grade. So for those younger age groups, of course, we're not talking to them about methamphetamine. We are talking to them about how do we be good friends? How do we make good choices? How do we cope with those stressors that we encounter? I feel like this is where we're really tying in so well with the presentation we had this morning from Laura, right? So the idea is that we're giving them those tools to navigate these tough choices, or for when we know inevitably they're going to experience tough things in their lives. Starting in about 6th grade, we do provide drug-specific information, but our approach, like I'm guessing many of you in this crowd, we don't frame substance use in terms of good or bad or right or wrong. Rather, we can frame conversations around what is healthy, what is unhealthy, what are the risks, what is the impact of this substance on our bodies. And the idea is that we're really empowering them to make those healthy and informed decisions for themselves. And that's our approach for young people or adults alike. So again, just kind of wanted to describe a little bit about what our organization does. We also have the department that I fall in, which is community strategy, where I spend my time doing things like this, providing training, education for any groups that are interested. And then we are not a treatment agency, but we do provide assessment and referral services, and that also includes our incredible peer support staff. I just think this is such a crucial component of providing substance use services, because there's a huge difference between a 16-year-old who gets caught at school with cannabis and a 50-year-old individual who's been struggling with an alcohol use disorder for the last 10 years. Like, those two people need different resources, right? But when you hear just like in general public or on a TV show and people are like, oh, they need to go to rehab, I'm like, do they? Like, is that the indicated treatment for them? Is that what is an appropriate next step? So I think that resource navigation aspect is a really, really important part of the services that we can provide a community. All right, so that's a little bit about Prevent Ed. Again, I wanted to thank Mary, the organizers of this conference, for being so thoughtful about pairing Laura and I together. We kind of had some email exchanges to make sure that we were collaborative in thinking about what are the things we can talk about with neuroscience and substance use. So we're going to kind of go in a different direction now and talk about that impact on mental health. So let me say too, then I'm about to show us our agenda. Since we're going to be talking about mental health items, and you know, we already talked about trauma and all those things this morning. We talked about some heavy topics. I just want to offer that warning, when we talk about mental health, I am going to discuss some outcomes related to suicide. So just want to offer that to anyone. Ask that we all practice self-care while we're sitting here, or if there is anything that we do discuss that is a point of discomfort, please do whatever you need to do for your own wellness. But I at least wanted to offer that up front, that the conversation will be headed there at some point. So here's what I want to talk about today. I want to really super duper briefly go over brain science and substance use. This is just to get us all on the same page. I'll talk also very briefly about the landscape of co-occurring disorders. What does the data tell us? But then we'll get into some specifics and talk about how does cannabis use, how does alcohol use, or even something like opioids, what is that direct impact on mental health? Because I mean, I think like we all get that. Substance use and mental health are connected, right? Like, I feel like a lot of people know that, like that happens, we're familiar with that, but let's go a little bit deeper and think about some of those mechanisms. And then at the end, I want to wrap up with also a brief conversation on psychedelics. This is going to be, again, quick, but it is something that's coming up in conversations more and more, especially as psychedelics are being framed as a therapeutic treatment for some mental health conditions. So I kind of want to give us the 101, kind of offer the areas where if you want to explore more, where those opportunities are. But I wanted to bring it up because if not, we're all thinking about it in this room. There's already been legislation filed in Missouri to make psychedelics accessible to certain groups for that therapeutic benefit. So it is something that's coming down the pipeline. I would rather us talk about it early and have that understanding so we know what we're getting ourselves into. All right, and I think questions, comments, welcome throughout. I don't think we need to be overly formal and say hold till the end. I'd rather spend this time talking about the things that you all want to talk about. Okay, let's get on that same page in understanding that what happens to the brain when people use substances. So I think we talked about dopamine earlier this morning, right? Dopamine is that hormone, that neurotransmitter. It is released in our bodies when we do activities related to survival, and it makes us feel good. And not just good, but really good. That nice, warm, fuzzy feeling. Did you all eat lunch? Yeah. Did it feel good? Yeah. Yes, that's because we need to eat to survive. So your body's like, great, thank you for doing that. And when we start thinking about dinner time tonight, that's probably going to start feeling good too, because your body's going to need to eat again in order to survive. So again, very closely tied with activities of survival. But dopamine is also released when people use substances. So when we eat, we get a bump of dopamine of about 150%. Okay, that's what's responsible for that feel-good reaction. With something like nicotine, it's a little bit higher. It's about 215%. If cocaine was on this slide, it would be 300%. Let's take a look at what happens with methamphetamine, 1,000%. But let's look at what happens with heroin and what substances could I replace heroin with and say instead? Opioids, right? So we're saying opioids. Give me some like generic or brand names. Oxy. Percocet. Vicodin, yeah, okay, all of these, right? So this is my own experience. I'm not pulling this from data, but I feel like, because I've been doing overdose prevention presentations for 10 years, something like that. And when we had like our oversupply of prescription pain medications, I feel like people kind of got it that like those prescription pain medications, that was similar to heroin. And I'll ask people now and they'll be like, opioids. And I'm like, yeah, but what are opioids? And then they're kind of drawing a blank. So I wonder if we're kind of missing that connection a little bit just because we have done such a good job talking about opioids in the media, but we kind of just left the branding there. It's an opioid, but that also means Vicodin, Percocet. So I also wonder if there's an opportunity for improved communication between the people prescribing those medicines and the people who are receiving them. Anywho, okay, so we have heroin here. We could replace that to say Vicodin, Percocet, any of those pain medications that we just discussed. So we see a 2,200% increase in dopamine. So for those of you who are familiar with those who struggle with opioid disorder, this should not be a big surprise because we know that when people use those substances, they can experience a tremendous euphoria from them, right? But what happens for any of these substances is that the body's not meant to have this much dopamine, and the body wants to balance itself out. So the way that it reacts to this flood of dopamine in the brain is it starts producing less, and those receptors on the brain that would grab onto those dopamine molecules to make that feel-good connection, they start to close up and they don't accept any more dopamine. So of course, everybody, what happens when someone goes to use that substance in the same amount the next time? Okay, I heard overdose, maybe before overdose. I think I got it. Okay, so it doesn't feel as good, right? And what do they have to do to feel as good? Use more or something stronger, which is maybe not the full answer of why we've seen fentanyl take over our drug supply, but maybe part of it, right? So of course, the process that we've just talked about here is the process of developing a tolerance to a substance. A lot of us have heard of that term before. All right, so I just wanted to kind of leave it off there that, you know, a lot of people, this is going back to those previous ideas that we had about substance use disorder being that moral failing, that it's someone's inability to say no. But there is that physical aspect. That's why we know that like medications for treatment are helpful, things like that. So as if addressing substance use disorder wasn't difficult enough on its own, when we have a substance use disorder diagnosis with one or more mental health disorder diagnoses, that is a co-occurring disorder. These things are happening together. So a lot of us might be familiar with sort of this story or this process where somebody's experiencing a mental health challenge, maybe they're feeling very depressed, they experience a lot of anxiety, and they start using a substance, and then that results in the substance use disorder following that mental health challenge, right? That's kind of the order that it goes in. We start with the mental health challenge, then we add the substance use disorder. And yes, that can absolutely happen. But what a lot of people are less familiar with is that it can actually go the other direction. So we might have someone who is not showing any signs or experiencing symptoms of a mental health challenge like depression or anxiety. They start using a substance, and because we know that substances change the brain and how it works, it can actually result in the onset of a mental health challenge. So somebody who maybe was not experiencing depression or anxiety before, now they are, and it is a result of that substance use. So either can occur first. And we also see people, of course, get into this cycle here. Maybe they feel really anxious. Anxiety is just an example here. They feel really anxious. They use a substance. The substance only exasperates that anxiety. Maybe there is short-term relief, you know, during the use of it. They get that dopamine bump, things like that. But ultimately, it's not addressing the stressor that they have in their life, and it's just furthering this cycle. So we know that this is the path that it can take. And, you know, if you needed convincing that either that, you know, having a co-occurring disorder can go in both directions, where either can start first, we just need to look to the DSM-5, and I know there's a newer version now, but there's actually a list of substance-induced disorders. And this is at least the list that was included in the DSM-5. So substance-induced psychosis, substance-induced depression, substance-induced anxiety. So again, if we needed to make that case for someone, again, that either can come first, or at least that the substance use disorder can come first, and then the onset of a mental health disorder, then this is what we can reference. Looking at prevalence, this is data that we have from the National Survey on Drug Use and Health, which, little side point here to make, unless someone tell me if I've missed like a recent piece of news, the National Survey on Drug Use and Health is no more. So this is a huge source of where we get our data to be able to understand what's happening in the landscape and make informed decisions about at-risk populations. I don't know what will happen with that moving forward. So I have this information for you now. I don't know if I will have it next year. But according to that 2023 survey, 35% of adults age 18 and over in the US who have a mental disorder also have a substance use disorder. The most commonly co-occurring disorders that we see with substance use is anxiety, depression, post-traumatic stress disorder, psychosis, borderline and antisocial personality disorders, and some others. Adolescents with substance use disorders have especially high rates of co-occurring mental disorders. This includes mood and anxiety disorders, conduct disorder, and attention deficit and hyperactivity disorder. So again, this is just some information that gives us a sense of the landscape, the prevalence to which co-occurring disorders are happening. Let's talk specifically about cannabis use in mental health. Let me add another sort of disclaimer here. In presenting this information, my intention is to discuss the facts that we know about cannabis and its interaction with mental health. I would never want to invalidate someone's own individual experience. So that is not what I'm here to do. Again, this is speaking broadly about the issue and just what the science tells us. You'll get why I'm saying that in a bit. Okay, so before I can talk about some of these concerns about cannabis and mental health, let's review, or maybe this is new information for some of us in the group today. We need to talk about THC potencies. So THC is the psychoactive chemical in cannabis. And when I say cannabis, I'm also talking about marijuana. I'm using those terms interchangeably. So it's the psychoactive chemical in the cannabis plant. It's the part that gets people high and what causes that euphoria. It's also the part that affects brains, especially young, developing brains. And, you know, when we think back to like the 60s, the 70s, when I feel like we maybe developed like some of our country's like formative ideas about cannabis. The cannabis that was being used back then was, first of all, mostly the raw botanical. So it was the plant material that was being smoked. And that cannabis probably had a THC potency on average of about 1 to 2%, which is pretty low. So that's what we had back then. And over time, we would expect an uptick. And in 1995, that average was around 4%, still pretty low. But then we saw the introduction of both medical and recreational cannabis programs across states. And what this does is it introduces big business into the equation. That is how, whether it's medical, recreational, doesn't matter. It is all being accessed through private businesses. So private businesses, well, business in general has not, you know, sometimes public health and big business have butted heads in the past. And that is because the goal of business is to generate revenue, right? They want to make money. They want to meet customer demand. And what do customers demand? Products. Higher potency products, right? So this is where we really start to see a hockey stick curve in THC potencies. So in 2013, that average was around 13%. And of course, fast forward today, and a lot of the products that are available, and call out anyone I'm missing, waxes, vapes, dabs, or even still the raw botanical, but it's just been bred to have super high potencies of THC. You can find products well within that 30 to 60% range. This is a lot of THC. When Colorado passed their recreational law, there was kind of a realization of like, oh shoot, these are really high THC products. And there was an effort to dial that back and restrict the amount of THC that products could have. Well, you can imagine how far that went. And other states learned lessons from that. And when Missouri passed our Amendment 3, which is our recreational cannabis law, they wrote in there that no governmental body or whatever agency can restrict the amount of THC that is sold. So they made sure to write that into the amendment, which is in our Constitution. So when it comes to THC potencies, at least here in Missouri, as far as what's sold or restricting them, our hands are tied. Yes, question up here.
So, I mean, that's like $1 million question, because, I mean, they are the legislature that's writing the laws, but who's the force behind it, making that provision? Because there's a driving force behind that. Like
marijuana industry.
their lobby, I guess.
Yeah. Yeah.
There's no other lobby strong enough to try to take on that lobby, because that's kind of ridiculous.
I think we're the lobby. I think it's us in this room, and I know that's why we engage in advocacy efforts and education. And I know that we kind of did a tour de Missouri when some of these laws were on the ballot. We're not going to tell people what to vote for, but we can say, here's what this law says. If that's something you want, then you'll vote accordingly. And if you don't, then so yeah. I mean, there is a tremendous effort from prevention to advocate for these things, but you think of alcohol, you think of tobacco, a lot of times it can get dwarfed. So yes.
Is there any evidence that legalizing cannabis has deterred any criminal activities? Like, has it, because it's been illegal, there's less illegal drug use?
So one of the cases that was made with having legal cannabis programs, so the commercial sale of it is that it reduces black market sales, right? That was one of the cases. From what I know, which is limited because that's not my role, the answer to that is no, but I see some gestures from the audience, so I'm going to welcome their input right now.
My name is Greg Brown, Community Behavioral Health Liaison with Missouri Crisis Intervention Teams, and my specialty is substance use. What Colorado, Oregon are seeing is that they are not buying from commercial growers because of government regulation and checking. They're going to Joe Blow down the street because it's a quarter of the price. And they're also seeing other entities making vast investments in the grow farms and in the transportation.
The place where you're seeing, I'm Kyle Duncan, I'm also CDHL. The place where people are actually seeing the street value stuff, you see these mom and pop shops open everywhere, right? These are not state regulated. But in 2019, there was a farm bill passed that said anything under 0.3% THC is legal. Everybody in here, you know what THC is? Does everybody in here know that what is the flower form is not THC, it's THCA? Until it's burned at a certain temperature, it drops one of the covalent bonds and then it becomes THC. So under the law, people are opening up these shops saying, I'm not selling THC, I'm selling THCA. Until they burn it, it's not THC. So that's a lot of what you're seeing is that these loopholes that people are using to get around the law. So these mom and pop shops that are opening up, the state stuff that is actually regulated, they have to send samples in to be tested with every batch that goes through and is tested and regulated. Mom and pop shops don't know where they get it, doesn't know anything about it. It's just like going down the street and buying on somebody else. There's no regulations other than, and to be honest with you, if law enforcement were going to those places, as marijuana ages, it actually will drop that bond as it ages. So it could be above that level, THC per se, but it's because of that law. It's because of the farm bill. You're seeing these pop up all over the place, and that's
big right now in Harris County. The exact same thing. That loophole is huge, and they're popping up everywhere.
They're literally mailing it now. It's not even the Delta 8 or Delta. It's literally they're just mailing it because they're saying that I'm not mailing THC. I'm mailing THCA. It's up to that person to create THC to burn it. So that's where you're seeing a lot of these mom and pops, and that's where they don't know where it comes from. It could be their cousin Gary down the street growing in his garage or his basement, and they bring it in. Who knows? But so there's no regulation on those mom and pop shops.
So we could spend a whole day on cannabis and THC. I'm gonna bring it back in. Back to advocacy. Yes, we advocate. There are scheduled prevention days at our state capitol. We have even youth prevention days where they go and express their concerns. So I don't want anyone for a minute to think that that effort isn't there, but just unfortunately there are bigger forces at play that often win out. So, yes.
To address the increases or decreases in criminal charges, I went to a really good training. I'm a case manager with treatment courts in Cape County. I went to a really good training where the man came in with a literal printout representation of the laws, the criminal cases in the system before legalizing marijuana in Colorado, and a whole table stacked full of the same thing since it was legal due to overdoses, children having them in schools, illegal sales. driving under the influence, like all of their cases, it literally walked down the court system.
And let me also just make a note to be clear. Legalization is not the same as decriminalization. Most organizations have the stance that no one should go to jail because they possess a small amount of cannabis, especially when we know that those policies disproportionately impact communities of color. So just wanted to acknowledge the differences in terms there. Okay. So we have these super high potencies of THC. So what I'm about to talk about with mental health outcomes, this is like not something new that we've suddenly learned about cannabis. This is not fear mongering. This is directly related to these super high potencies. Actually, we have a video, sorry. So let me shift over. I wanted to show us a little bit about how cannabis could impact our mental health. Sound isn't working, sorry everybody. We'll figure it out, or we won't. This is a really great video that discusses the impact of cannabis on the cannabinoid system. A lot of this is probably what you are all familiar with. It's actually also a recap of what happens with dopamine. But if you're interested in that deeper dive, if this is helpful in how we maybe educate others about that impact on the brain, I am happy to share this with you. I also like this video because I feel like it's pretty fair. Like it also explains like why people might feel good from using cannabis, but then what can be the downside of that. So if anybody's interested, I can always email you. Okay, let's continue. All right, so this is where I was going. So let's look at this interaction between cannabis use and mental health. This is a very dated chart. This is from 2014. But the reason I show it is because this is the best chart I've seen where it puts all of these different mood disorders together. And what we are seeing here is the blue bars represent the population of individuals with marijuana dependence, and the green is the general population. So what we're seeing for each of these mood disorders is that there is a higher prevalence of them in those populations with marijuana dependence than the general population. So this is the case for all of them. I said this information is dated, so let me provide something a little bit more up to date. So this is looking at our National Survey on Drug Use and Health results from 2021. Here we have people who experienced, or we have cannabis and people who experienced past year major depressive episode versus those who did not experience a past year major depressive episode. You'll see that those with cannabis use, they're experiencing more of that past year major depressive episode. Looking at cannabis use, severe mental illness, any mental illness, or no mental illness, that's what those bars represent. Again, we see severe mental illness happening more often with higher cannabis use. And then we also have some data related to suicide. So this is serious thoughts of suicide, made any suicide plan or attempted suicide, and we're comparing all adults versus those with past marijuana use. Again, serious thoughts of suicide being higher in the group of those that report past year marijuana use. Same for making a suicide plan, or same for suicide attempts. So this is not like a trickle of evidence. This is not like a few data points here and there, a journal article. This is an onslaught of evidence that we are starting to see that there is a connection between THC exposures and these mental health outcomes. And the really interesting thing is that, and this is why I made that disclaimer before I started talking about cannabis, is you all probably have heard someone describe their cannabis use as it being the only thing that helps them for their depression or their anxiety. It's the only thing that helps. But here's something that could be happening. A lot of cannabis withdrawal symptoms mimic the symptoms of psychiatric disorders. So you think about things like anxiety, irritability, craving, insomnia. People might report those as like a symptom of a psychiatric disorder, but those are also symptoms of cannabis withdrawal. So what can happen is they feel crummy because they're experiencing that cannabis withdrawal. They use cannabis and they feel better. And so it's actually reinforcing the idea that the cannabis is helping, when in fact it's just the cannabis that's allowing them to get back to their normal, right? Because in its absence, they're down in that withdrawal zone. So just something interesting again, because I feel like that's a very common claim that people will say it's the only thing that helps. It might just be that they're stuck in that cycle. A little bit more evidence, but thinking about a different mental health disorder. We are seeing an uptick in THC exposures among pregnant women. There's been an increase with that. You can see the data right there. And some researchers up at WashU did a study. They were looking at prenatal THC exposures and following those kiddos a little bit later, looking at the outcomes down the road. And they found that those young people that had that prenatal THC exposure, they were more at risk of having episodes of psychosis later in life. So, you know, I love my job, but if I could make my own dream job right now, I would go work for whatever OBGYN association right now, and I would just be screaming and yelling that we need to have messaging and communication about THC use during pregnancy. Because if you call to, someone did a study, they called around to some dispensaries in Colorado, and maybe you've heard of this, they're actually recommending cannabis products for pregnancy symptoms, for morning sickness, things like that, saying that it's safe, which that would be at odds with what our medical guidance would tell us.
Can I ask a question?
Yes.
I'm certainly not advocating for one, so I'm gonna get on my case. With the pregnancy percentages and the outcomes of those children, has there been a comparison of those mothers that are taking prescribed mental health medication and the percentages of those children and the potential for certain psychosis episodes?
If taking prescription medications during pregnancy results, I couldn't.
Prescription mental health opposed to if they're doing the THC for mental health to see.
I'm seeing where you're going.
Comparison with the two.
I don't know. The best thing I could offer is to reference that study. My guess is that because this is the nature of good studies and research is they take out those confounding factors. So we would probably have to compare what two different studies say about
Because that's with our population we serve, that is where some people, if they are saying I'm going to do the THC, provide me with a different statistic opposed to me being prescribed whatever other pill. So it would be nice if there was something out there where we could show to say like, okay, you know, this might not necessarily be better for you to smoke this or.
Well, and where I'm going with this is, wouldn't it be great if a provider felt equipped to navigate that conversation with someone? They have someone in front of them who's saying, this is what I'm experiencing and I am struggling. Here's my solution. And having that non-judgmental response from a provider to really, again, help them make those informed decisions. Like that's my vision there, right? So thank you. That's a really great question. Okay. Okay.
Oh, this is all right. I'm gonna have to talk fast. No, sorry. I just think your point about educating pregnant women proactively versus putting them in the withdrawal and harming the baby if you catch them while they don't feel like you want to pull that substance away and cause adverse effects from withdrawal if you were just describing.
Oh, okay. All right. Let me be clear. I am not I am not an OBGYN, nor am I in addiction medicines, but I think that it's about having those conversations and thinking about best outcomes for everybody, right? Yeah, so, yeah, thank you. Okay, so let's circle back to what the American Psychiatric Association says about cannabis as medicine. They do not endorse cannabis as medicine. They'll say there's no current scientific evidence that it's beneficial for the treatment of any psychiatric disorder. In contrast, evidence supports at minimum a strong association of cannabis use with the onset of psychiatric disorders. And of course, they're acknowledging that adolescents are particularly vulnerable to harm. So this is where their position statement stands. So again, I would never want to invalidate anyone's individual experience. This is just sort of what that consensus is within the medical community. Here's the other thing. You know, people are so resistant. I get a lot of pushback, like, oh, you can't become addicted to cannabis. It's like, okay. This is a Men's Health magazine article that says this is why giving up on weed after years of smoking can feel so miserable. And what they're talking about is a withdrawal. So I just think it's so funny that a mainstream media source can be acknowledging that withdrawals are real, but we still sometimes see that resistance to to those harms, those concerns that we have with cannabis. All right, moving on. Let's talk about alcohol. So, like maybe even acute impacts of alcohol. Alcohol is not good for our brains. It shrinks our brains. Alcohol also impacts our livers, which can disrupt hormones. So for a lot of people, that can have an impact on mental health. It also, alcohol kills bacteria. That's why it's used as an antiseptic in certain situations. So it can really destroy someone's gut microbiome. And I don't know if, I'm not going to get into this, but like you've probably heard like this gut-brain connection, right? That the two are very much intertwined. So not only does it impact that gut microbiome for someone, but some alcohol can also create an excess sugar, which will actually create more bad bacteria or yeast for someone in their body. Alcohol is really dehydrating. Being dehydrated is not a good thing. And it also leads to poor sleep quality. And when we have conversations about just mental health, one of the most important things that always pops up is getting good sleep, right? So even just thinking about acute use of alcohol, this is how we could see some impacts on mental health. We also see risk factors for suicide, and these could be grouped into what we call distal risk factors or proximal risk factors. So distal is going to be something like long-term that the person is experiencing in their life, something related to alcohol use, but what might precede suicidal behavior. Proximal risk factors are variables that increase suicide risk in moments immediately before that suicidal behavior. So you think about somebody who's under the influence and some incident happens, that could be that risk factor for suicide. Some other risk factors, interpersonal loss. Over 1/4 of those with alcohol dependence who died by suicide experienced interpersonal loss within 6 weeks of their death. And there's also recurrence. Those suffering with alcohol use disorder are at a greater risk for suicide during periods of active alcohol use. And the last slide here, thinking about suicide behavior during alcohol intoxication. If there was this study that showed that consumption of over 10 standard drinks increased risk for suicide attempts by 90 times in comparison to abstinence. So kind of an interesting way to think about alcohol and suicide is that acute intoxication is a greater risk than habitual use. So yes, we're concerned about people who have an alcohol use disorder and the risk factors associated with suicide, but we also need to worry about people who might just have too much to drink in an occasion, right? There's still that risk for suicide there. Okay, some of the reasons for that, alcohol myopia, which is the immediate and usually painful aspects of experience, take on disproportionate weight in the delicate balance between choosing life over death among those contemplating suicide. And we also know that alcohol can interfere with inhibition conflict. So alcohol intoxication acts to interrupt inhibition conflict through alcohol myopia, leading to more excessive responses that wouldn't have occurred if the person was sober. All right, so a few more, I think maybe one more slide on opioids and suicide, and then we'll move away from the conversation about suicide. So thinking about opioids, if anyone has also done suicide prevention work, you might have heard of this, especially when we talk about like gray area suicide. With overdose deaths, there is some guesses that many of those overdose deaths are people who had decided to take their own life. More than 40% of suicide and overdose deaths in 2017 were known to involve opioids, and many more that maybe went on unrecorded. So this is because we might have seen intentions. Somebody might have left a note before an overdose. Maybe somebody was just feeling indifferent, or I don't care if I don't wake up, something like that. In a study of current and past overdose experiences among patients seeking treatment in a Flint, Michigan ED, 39% of those whose worst overdose had involved an opioid or sedative reported wanting to die or not caring about the risks. Another 15% reported that they were unsure of their intentions. So there's also that interaction between opioids and suicide, or should we say overdose and suicide. This like AI computer program also reviewed some overdose deaths and ruled that many of them were likely to actually be suicides, maybe up to 1/3 of them. So when we think about all our efforts with overdose prevention, you know, which we have a lot there, we have naloxone, we have harm reduction, things like that, maybe we can also be thinking about that risk of suicide as well. That's sort of the practical takeaway there. Had another really good video to kind of sum all that up, say these things a lot more succinctly than I can. We'll see if maybe we circle back to it. But we'll keep moving here just for the sake of time. Okay, let's talk about psychedelics. Like I said, this is just an overview. I'm not getting deep into this. This is just the 101. So depending on which psychedelic substance we're talking about, so there's some examples that we see up here like psilocybin, LSD. Ketamine is sometimes not lumped in to the group of psychedelics. It's considered to be dissociative something, but sometimes it's just not in the same conversation with a lot of these other substances. There's also something like MDMA. There's like ibogaine. What am I missing? I said psilocybin. Any others? Okay, all right, we'll keep going. So depending on which substance it is, it's going to impact the brain a little bit differently. So when we're looking at something like psilocybin or LSD, that's going to affect brain receptors typically activated by serotonin. It disrupts communication between brain regions, and we'll see why that is important to understand in just a minute. When we're looking at something like PCP, ketamine, it affects the balance of brain chemicals. Something like MDMA also releases serotonin, but also dopamine, some other brain chemicals. So they all work a little bit differently. But what you are probably hearing about in the context of therapeutic benefit for psychedelics, that it's helping people with depression, and when we're talking about depression, we're talking about like extremely resistant depression. So these are folks that have kind of tried everything, and these are also people that are experiencing mental health challenges that are debilitating. This is not just someone having a sad day. So this image is what pops up a lot when people are explaining what the benefit is. And the best way I can summarize this is that this is what we might see in a normal brain as far as like neural pathways. And when somebody is using psychedelics, it not just increases activity on these neural pathways, but it increases the number of neural pathways. So what that means, and I think I have a slide that's going to say this in a minute, is that it's allowing people to, I guess, get out of their own heads and think in ways that they haven't before, or step out of their, I don't want to use the word problematic, whatever thinking patterns that they may have been stuck in previously. That seems to be how this experience is described for folks. So here we have an explanation. Psychedelics induce the brain to change transiently in ways that appear to allow a reset to take place and permit alterations in previously stuck ways of feeling and thinking about things. So currently there is research to explore using psychedelics to treat, like I said, treatment-resistant depression, PTSD, and also substance use disorders, okay? But before everyone gets too excited about psychedelics, let me also offer just a few notes about it. This is what a therapy session might look like for psychedelics. So what I'll point out here is that there's 2 people in the room with the person who's receiving the treatment. And also think about this treatment. This is not like a, hey, I'm gonna pop in 20 minutes and then be on my way. This is a much longer session that the person is experiencing.
So how long are usually the sessions though? And how many sessions do they usually get?
I think that depends on the study. From what I've heard, a session is around 8 hours. That's the allowable time for a session. 8 hours. And I think depending on the person, what I've heard is that the number of sessions, it sounds like it's in the range of like 1 to 5. So again, not an expert in psychedelic therapy here. So where you're going, great, you just introduced my next slide. Let's talk about some concerns even with using psychedelics in a therapeutic context, because now you're hearing all these people, they're like, oh, I'm certified in psychedelics. It's like, ooh. Effects can vary widely, right? Even with any substance, all of our bodies are different. We're all our own combination of unique risk and protective factors. We metabolize substances differently. People are going to have different reactions, and the effects can vary. There is a lack of professional consensus right now in like the psychiatry world of whether psychedelics alone can be utilized as a treatment or whether it needs to be complementary. In other words, we don't want to have somebody using psychedelics unless we're also offering other therapeutic supports, right? That ongoing interaction with a mental health professional. Again, right now, they are only indicated for certain conditions, not everything for everyone all the time. And in fact, it can actually worsen symptoms for some conditions like schizophrenia. And there's also some consent and safety concerns. I pointed out how there were 2 people in that room. That's kind of the ideal setting. I can't speak to any specific case, but the reason I know that this is being discussed is because there has been a concern for something like sexual assault to take place, for things to happen when this person is not of their usual mind, and there's consent issues there. So when we think about the practicality also of utilizing this treatment, best practice treatment, and if we want to argue like, well, look, we got to get folks what we can as soon as possible, like that's an argument to be had. But when we think about the implications of how we fold this treatment into what we know is like our medical and healthcare system, this is very resource intensive. 2 practitioners for 8 hours. I mean, I'm just thinking about cost and space and logistics. So even though there's lots of promising information about this, I think we want to make sure that we are moving forward with the consideration of psychedelics as therapy in a very tempered way where we have integrity to the process and we have reliability to make sure that we're keeping people safe.
What would be the cost for that therapy, psychedelic therapy?
I'm looking at my healthcare people. Give me
Well,
a
I mean,
ballpark.
typically a 1 hour standard to do like EMDR is $600+ in Cape, so.
There's a fairly popular podcaster that I listen to. His name's Sean Ryan, and he was a veteran and a CIA contractor, and he had a lot of trauma, a lot of PTSD, and he very highly advocates for the use of iodine and some of the other psychedelics. And there's a treatment facility in Mexico. I think it's like $14,000. It's like a week-long program.
Yeah, and again, like, we can acknowledge that therapeutic benefit. I think the prevention professional in me is watching the parallels of what we just saw happen with medical cannabis. And while we can acknowledge therapeutic benefit for some people and certain conditions, that doesn't mean our directives is everyone should have access to this for everything all the time, nor should it fall into a commercial system where people stand to make money off of it. That's what I mean by those systems. So lots to think about, but again, I at least wanted to present that. It's something that's interesting, that's on the horizon. We'll be doing a lengthier presentation going much deeper with this in February, I think, at Prevent Ed, if that was something that you had more interest in. And there are actual documented adverse health effects associated with psychedelic use. We do see some negative short-term effects, and this could even be like somebody having a really poor experience. It could be something like they're experiencing a secondary injury. If they're not supervised, they think that they can jump off a second floor balcony, something like that. But we also see long-term effects. There's some psychedelics that can impact people's hearts. Some people are experiencing kidney issues. There's a list of some, even though, not that it happens often, but there are some documented negative impacts of using them. There's also a concern, again, outside of these controlled research studies right now with people having access to psychedelics, that there's adulterants, just like we have that concern with any other substance. And also drug interactions, that if people are sort of taking them on their own and not understanding how it might interact with another prescribed or not prescribed substance that they're also using. Another position statement from the American Psychiatric Association, they say there's currently inadequate scientific evidence for endorsing the use of psychedelics to treat any psychiatric disorder, except within the context of those approved investigational studies. They support continued research and discovery. Clinical treatment should be determined by scientific evidence in accordance with applicable regulatory standards and not by ballot initiatives or popular opinion. So hopefully that recaps what I just said, and I said that effectively. All right. Okay, so last slide. Let me try to end on a positive note. And I am not endorsing this. This is just me sharing a resource that I think is really interesting. I participated in this, there's this organization called the Academy for Addiction and Mental Health Nutrition. And I think it's this small group of people. But I participated in one of their trainings, and it was really eye-opening for me. So if I were to ask you all in here, what is like the vitamin and mineral you need for strong, healthy bones? What would you all tell me? Calcium. And I think I heard some vitamin D, that works. But right, and where do we hear about getting calcium from? What are we told as kids? Milk. Drink your milk, right? So you get strong bones, right?
I don't like milk.
Okay, I don't like milk. What vitamin or mineral do you need to support good mood?
Zinc. B12.
Okay, so we see what the demonstration was there. We're not as familiar, right? Like, we know that we need calcium for our bones, but we don't learn as much about that role of nutrition in our brains and mood and things like that. So I participated in a 3-day training, which was way deeper than I ever needed to go in nutrition. I was like, this is too much. I cannot talk about quinoa anymore. But it is really interesting when we think about supporting people with substance use or mental health challenges, that there's this really crucial role of nutrition. And it makes so much sense that if we're not nourished and we feel crummy, that is a risk factor for use. That's where this all comes together. So if you're interested, they have some online videos that you can watch. They really emphasize the importance of protein, and not in a TikTok way. They're not this is not advocating to eat a raw steak or anything, but thinking about those sources of food, and how, if we can stabilize someone's mood through nutrition, then that's a helpful tool for them in just maintaining that balance. Somebody mentioned vitamin B. That's actually something that the trainer advocated for, that instead of at an AA meeting, instead of having coffee, they should just have vitamin B sitting there, just because they know that that can be really helpful for someone. So I just wanted to offer that again, kind of putting all this together about mental health. Again, I thought it was cool. I encourage you to look into it, and it really does made me think differently about how we can support people who are maybe struggling with substance use challenges, mental health challenges, or those things together.
What's the full name of the academy?
Yeah, it's so small. Academy for Addiction and Mental Health Nutrition. One of the trainers, I think she started her own nonprofit branch, and it's called Protein Saves Lives. But on here, there's really, again, just helpful videos, resources. When I took the training, there were actual chefs who work at treatment facilities, and they were considering a lot of these things, like how to fold it into the food that they cooked for the people within those facilities. Like I said, it was just super interesting.
Can you just give us a couple nuggets that we can share with our clients besides vitamin D?
B. what I took from it was B and protein and amino acids. Protein and or amino acids, because that's where we get amino acids from, is protein.
Our host, something on just on this topic.
I actually did at Prevent Ed. No, well, and maybe it's a topic for all of you. The speaker was very kind in offering to, speak with us, and also I think it helped that several people from our organization took her training. So maybe if you want to send a few folks, kind of feel it out. Maybe she might like to come to talk to a larger audience. Again, it's probably more in-depth into nutrition than anyone in here wants to get, but you do get some stuff out of it. I would say rather than my tidbits, watch some of their videos because they have them easily accessible on the website.
What's the cost for the training?
The training that I took for 3 days was $180. It's not the worst thing ever. Yeah. Okay, everyone. Any lingering thoughts or questions?
Wait, I got one thing. I understand that you were talking about the therapy with the psychedelics, the 8-hour treatment, all of that, but have you looked into or discussed or seen or read on anything about the microdosing that people are doing, where they're only taking like 0.3 of something or 0.3 of the psychedelics, and it just lifts their mood and makes them feel better, and it's something that they do, like they take it for so many days and they don't, and they do it and they don't. My husband, before he passed away, he was really into it. He looked up all that stuff and how to microdose and things.
Yeah, so that's happening. Google searches for microdosing have gone up, especially following the pandemic. Let me try to say this like so succinctly. It's not so much a concern for an individual's use, it's about the system in which people are accessing it. And that's the parallel that I'm seeing with cannabis. So when we were talking about cannabis legislation, I had somebody in the audience stand up and he's like, look, I have stage 4 cancer. This is the only thing that helps me. And I think he kind of wanted to push a little bit. And it's like, I know this is going to be hard to understand, but I'm actually on your team. Because if you get benefit from cannabis, I want you to have the best, most safe product available. And the way things are regulated, I can't offer you that assurance. And I don't know if you've heard about like how much mold now they're finding in commercially sold cannabis, because we do have some FDA approved products that are derivatives of the cannabis plant. So I know that it's moving in that direction, but like I said, then we get into this cost balance thing. It's like, well, I understand you want access now, and but now we have the commercial sale of cannabis where it's available to anyone for anything at any time. And it's like, okay, well, how can we have informed conversations with our doctors? I don't know if somebody's like going to bring their illicit psychedelic product like into their doctor and be like, how do you think this is helping? It's just this real butting of heads of two different approaches to, I think, managing our health. There's that Western healthcare model, and then there's, I think, what people may want to try on their own and experiment with, maybe out of frustration with Western healthcare. I want to be fair there as well. So yeah, it's like I don't have any comment on it other than the concern for how it's accessed and the limitation of a provider to offer insight about the cost and benefit of that use. Anything else? All right, everybody, thank you so much for your time and attention. I forgot all my business cards, so if you'd like to get in touch with me, my email is at the bottom of this slide.